All right, we're live here, and I'm here with Dave from NYC Pain MD again, and I'm going to keep my introduction short because he has some great information on gel injections for knee arthritis versus surgery, and if you should get it, and some great information. Dave, you're here?
Yeah, I'm in. Thanks, Brad. Good afternoon. I know we only have a few minutes, so I want to get right to work on this. And as you know, we always try to bring patients the latest. A lot of times, proper news is not disseminated. And of course, transparency is paramount, particularly when it comes to healthcare. And that's always got to be the way it should be. But listen, medicine is clearly moving away from the use of the knife and in favor of really like what we call elegant, minimally invasive approaches. And, now our goal is to avoid intrusive methods and allow patients to avail themselves to the most minimally invasive, high-tech but natural treatments available. But this really caught my attention. Right in the Los Angeles Times, probably one of the biggest newspapers in the country, there's an article and a column from a patient that wrote in. And here's the title of the article: "The Insanity of Covering a $50,000 Knee Operation but Not a Relatively Cheap Injection." That is the exact title that appeared. And the patient goes on to describe, this guy's name was Jerry. I'm not going to give you the last name. And he said originally he was under Medicare and he was going under the injections, which he called this gooey gel that gave him a lot of relief. And he would do it about once a year. And it cost maybe $1,000 a year. Somehow he got switched over. This is a new thing Medicare is doing. And all of a sudden, the one plan that for whatever reason decided not to cover these lubricating treatments, and he's got no options now. And they said, go get a knee replacement. And his question is, why would you let me do? I was doing great with the gel injections. I felt better. It kept me out of surgery. Why would you want me to do a $50,000 procedure? And he goes on and on and on in developing this. And so I think that's the question that you have to answer. And physicians should be given the latitude to decide that let's try these injections instead of going to surgery. And with all the political stress and pressure and the cost of healthcare, President Trump now talking about allowing to import medications and putting pressure on drug companies, how could insurance companies turn their back? Now, I will say this. Most of the insurance companies have smartened up and they realize the vast amount of dollars they're saving by patients getting these lubricating injections. So by the way, Brad, we should tell patients, if this is the first time you listen, one of the specialties that our physicians do is called image-guided or precision-guided viscosupplementation. We're under a special medical camera. The docs will take an arthritic joint, shoulder, hip, ankle, hand, knee, and inject in these natural FDA-approved lubricants. The vast majority doing much better and many avoiding surgery. I'd like to connect this to a very important, what I believe perhaps the best study ever done, a landmark study you and I have talked about, by an orthopedic surgeon down in Louisiana. He went back and charted 2,000 cases. Now, this is really important, Brad. Every case that he used was what we call bone on bone. It's called grade 4 Kellgren-Lawrence. Lots of bone spurs, very little lubricant left, natural, all rough, very narrow joint space. This is called grade 4. And then, Brad, he offered them the choice of major knee surgery, a replacement, or let's try some gel injections under guided imaging. And he put them through a series of several weekly injections. And just to review, here's what he found. After about 10 years, he went back and gathered information, followed up on 2,000 patients. And lo and behold, only three out of 4 still did not need the surgery. 3 out of 4 avoided a $50,000 plus surgery. 1 out of 4, the 1 out of 4 did still need to go surgery, but interestingly, on average, they were able to delay their surgery by somewhere around 2 years. So even for those that ended up with the surgery, they still delayed it 2 years, but 3 out of 4 never got the surgery. We don't know how long that'll maintain. I suspect for a long time, and they'll never end up with it. But we now have data that shows 75% of the patients can probably completely avoid knee surgery. This is a landmark study. Yet, 1 or 2 insurance companies decide they're going to save a few dollars up front on some joint injections only to push patients to surgery. This absolutely makes no sense. We don't understand it. Now, the doctor that did this study did go on to say that based on his earlier study in between in 2007, that in a cohort of 100,000 patients, if you did the gel injection treatments, you could save insurance companies close to $10 million. That's just in a group of 100,000. Spread it out over the whole country, 300 million people. Also, 2019 prices. You're talking hundreds of millions of dollars being thrown away on unnecessary, complex, and risky surgery when a few simple knee injections under guided imaging could do the trick for many of those patients. So this is what I wanted to bring out, and I really think that patients really have to start paying attention to this. If your insurance company is an oddball, the 1 out of 100 doesn't cover, you got to get on the phone and start to push and plug. If your doctor thinks that this is the way to go and you should try it, no insurance company should be blocking you up because the data is too strong. Why would they? We don't understand this, so we have to make patients aware. Fight for this right. Don't go to surgery because your insurance company won't pay for a handful of gel injections. Worst case, go on a payment program and do the gel injections first before you get anesthesia, surgical risk, post-surgical complications, et cetera, et cetera, et cetera. So I wanted to bring that to you today, and I know you're really interested in all these things, so I thought you'd find it really, really up to date. And write in a column, health column in the Los Angeles Times.
Yeah, it's really interesting because it seems that insurance companies make decisions for doctors as opposed to the other way around. And, you would think that they would make a decision based on money. It's business. Right. And what you're telling me there and telling everyone else there is that it's a terrible decision even based on the money.
Right. And an insurance company, they're always really looking at the costs. They have all sorts of accountants looking at it. Let me bring up another thing about surgery. And by the way, sometimes that knee replacement is what a patient needs, and they should have it. And surgeons do a good job. However, let me read one thing that appeared in the research of this orthopedic surgeon, very well known, talking about orthopedic surgery. I'm just going to read it word for word. Here we go. One of the benefits of delaying or avoiding TKR, total knee replacement, in older individuals may be to avoid risk with surgery or with subsequent required revision. Let me chime in. A revision is a second surgery because the first one didn't take or didn't hold. Doubling the cost, doubling the risk. That was an interjection. Let me move on. From the article, the complications associated with total knee replacement have been extensively studied and include the following: infection, pulmonary embolism, an embolism is a blood clot, thromboses, a blood clot, fat embolism, blood clot, hemoarthroses, bleeding in the joint, patellar fracture, that's your kneecap, heteroptopic ossification, meaning you get bone spurring, urinary complications, vascular injuries, nerve damage, and increased mortality. The word mortality means death. A recent study showed that post-operative mortality, or death rate, more than tripled in patients above 85 years following primary hip or knee replacement compared with patients that were 10 years younger. In a 10-year survivorship analysis, greater mortality rates after total knee replacements were shown to be associated with increasing age, poorer health, smoking, and rheumatoid arthritis. Now, collectively, he goes on and says, these studies underscore the importance of delaying, and I will add in avoiding, total knee replacement in certain patient populations, and also encourage the need for more well-tolerated, less invasive treatments and options for these patients. I want to again reiterate that all these patients were not light or early arthritis. This was advanced arthritis. So if you go to a doctor or a surgeon and says, oh no, you have advanced arthritis, that stuff won't work. Well, point blank, our physicians would not agree based on the research, not based on their opinion, based on the research. And I'm reading it to you right here. So I guess, you can sense the surprise on our part. And basically you're there open mouth trying to figure out what is the medical and insurance world thinking about not allowing and even encouraging people to do this before they even, consider surgery. Not in all, but in many cases. So that's my words of wisdom for today.
I know that you're you're short on time today, but could you quickly describe the procedure NYC Pain MD does for the gel injections you're talking about here with the guided imaging and stuff?
Right. Well, let me explain the guided imaging. Um, if you are but if you're grade 3 or 4, grade 3 or 4 means more advanced. The higher the number, the more advanced the arthritis. And Brad, we've talked about the greater the arthritis, the deeper, the more advanced the arthritis, the more narrow the spaces between the two bones. Maybe we should describe what arthritis is. Arthritis is the failure to produce enough lubricant in a joint, allowing grinding and wearing of the cartilage, the surface that coats the bones, causing to get bone spurs, roughening, inflammation, and grinding down the cartilage so much that the space between the bones narrows. Now, on a daily activity, if you've ever tried to thread a needle, or even worse yet, thread a needle in the dark, there's a very good chance you'll probably miss the needle hole. So when you try to go in, and I'm not a physician, but I'm speaking on their terms, when you try to go in as a physician into a joint that's very narrow, like threading a needle, there is a chance that you'll miss that joint space. So how do you get around that? You use something called fluoroscopic imaging. We termed our technique precision arthritis targeting. Here's how it's done. The patient's knee is put under the medical camera, the fluoroscope. The patient's knee is numbed up, freeze sprayed, numbed up so you don't feel it. And before the doctor puts any medicine into the knee, he injects in a little bit of a milky white contrast media. He's looking in live motion to see if that milky white contrast media went right between those two arthritic joints. If it did not, he simply pulls the needle out. You're numbed up, it doesn't hurt. Guides the needle a little better, watching on a camera, injects in more contrast media until he knows 100% he's right where he needs to be. Now, without moving that needle tip, he simply changes the syringe of the chosen lubricant and injects it into the knee joint. This is virtually painless. You're all numbed up. The doctor simply puts a small Band-Aid on the knee. You put on your coat, you walk out, you go home and rest for 24 hours, ice down the knee a little bit. Some patients even go back to work. It's all of about a 10-minute procedure. Typically, it's done once a week for between 3 and 5 treatments. There are one-shot injectables that are triple doses. We don't find them to do nearly as well, but they can be used situationally. So that's the basics of what's done, and specifically at NYC Pain MD.
And you guys offer a free screening evaluation. Is that correct?
We do. Our position is that we don't want patients to spend hundreds of dollars out of pocket to find out maybe that we can't help them. Here's the patients we can help. Some patients have not done anything for their knees, and they need to try some simpler things, some physical therapy, some exercise, maybe some over-the-counter painkillers, and see if it helps. If it does, then frankly, you don't need us. They haven't breached or pierced the algorithm or need for it. Some patients, Brad, in all likelihood, are so severe they absolutely need surgery, and we will send them. But those that need it, we can let them know on the spot. So we offer the exam, we take an x-ray, the doctors ask them questions, and what we'll do is make a recommendation, but the patient's under no obligation. If they want to move forward, they can. If they don't have to. There's no stress, there's no pressure. It's very thorough, but it's very casual and very comfortable. We want patients to get the information they came for and then make a decision how they'd like to proceed from there. It's as simple as that.
And what I'm going to do, I know you're short on time, and thanks for coming in today and having this talk with me. I'm going to put up the number on the screen here that they can call if they want to get a free evaluation screening. Give it a call, and the number's up on the screen now. So Dave, thanks a lot again. I know you're short, but great information. The research backs this stuff, and you guys, I know you guys are getting tremendous success there. So anybody who wants some help, knee arthritis, and also you're doing shoulders and hips and stuff like that, right?
True, we didn't talk about that, but there's some really good data. We'll talk about it next time. There was a great Italian study on hips, 240 people. All of them still didn't need hip replacement 2 years later. So let's plan on that for the next time. and I got to hop here, but we'll talk soon. Okay.
Thanks a lot, Dave.
All right, Brad. Thanks. Okay.
Bye bye.